Welcome to Living with SVT, brought to you from SVT Pioneers at Duke University, Durham, North Carolina. I'm absolutely delighted to welcome one of our medical advisors and an Arrhythmia Alliance SVT pioneer, Dr. Jonathan Pasini. Dr. Pasini, thank you so much for joining us.
Well, thank you for having me. We're very excited to be here for this Living with SVT session. And I'm very delighted to be joining you from Duke University and to have two of my colleagues with me who are outstanding electrophysiologists as well as educators. And so joining me today from the Dartmouth Hitchcock Medical Center, as well as the Geisel School of Medicine and the Dartmouth Institute in New Hampshire, is Dr. Emily Zeitler, who's an assistant professor of medicine at Dartmouth. And also joining us today is Dr. Larry Jackson, who is a colleague of mine here at Duke and the Duke Clinical Research Institute, who is also an assistant professor of medicine here at Duke. And I'll be starting us off today by just giving everyone a general introduction to supraventricular tachycardia, or as it's often better known, SVT. And then I'm going to be turning it over to Dr. Zeitler and Dr. Jackson to tell us more about the treatment and management of SVT. Pictures are always more helpful than words. And so this introduction will harness a lot of pictures. But before we start, just some general information. So SVT is a very common problem. It's one of the more common difficulties we see with heart rhythm in our clinics. And it does affect individuals of all ages. It can affect very young individuals in their teenage years, sometimes even in early childhood, and it can affect people in the middle of life, as well as older individuals. And the actual incidence peaks in the 5th decade. The risk is 5-fold greater in individuals over the age of 65. We define SVT on the EKG as the beats from the bottom chamber being narrow and greater than 100 beats per minute. Another name for this disorder that you might hear in a doctor's office is narrow complex tachycardia. And up to 1 in 6 patients with this problem can experience passing out. So that's some background information about the condition. The Arrhythmia Alliance, as many of you know, has many wonderful resources. But I do want to point out that there are these articles called the Cardiology Patient Pages in the Circulation Journal. And you can find these things by searching on the web fairly readily. And there's a very nice cardiology patient page written about supraventricular tachycardia that reviews a lot of the information that patients and families want to know, not only about the condition itself, but how we evaluate it and how we manage it. And so this is written specifically for patients and their families, and I think you will find this useful in the future. So it's always good to start with normal, or what should be happening, and shown here is an EKG of normal sinus rhythm. And behind each of these big spikes, you see a little narrow undulation called the P wave, which is the electrical activity from the top chamber of the heart. And the big spikes are what we call QRS complexes. And so there is a P wave and then a QRS complex, and they're occurring at a regular interval. And this is normal rhythm. And the details aren't important. The goal is not to get anyone to be able to pass a medical school examination on the cardiovascular system. But again, a picture is worth a million words. So this is what normal rhythm looks like. And here's someone who's in supraventricular tachycardia. And you can see that the rate of the complexes on this EKG are much, much faster. And this is no longer a regular rhythm. And I'm going to show you a picture of one of these abnormal rhythms. This chamber you see up here is the top right chamber of the heart. And this color band that is propagating through here is the abnormal rhythm, the SVT. And this is the rhythm that the patient is in this prior EKG that I showed you. This rhythm is AV node reentrant tachycardia. And we often explain it to patients as a dog chasing its tail in the center of your heart. And we'll look at some additional pictures of this abnormal rhythm in a little bit. This is a picture of a slightly different SVT. This is a picture of atrial tachycardia. And what we see here is the beat on the left of this screen is a normal beat. This is not an EKG. There are EKG strips at the top of this picture. But what you see here is on the left, there's a normal beat, and then there's these three beats all together. And this is atrial tachycardia. And you can think of atrial tachycardia as a spot in the heart that gets itchy and fires repeatedly and makes the heart go fast. So we've talked about SVT, who can get affected by it, how common it is. We've reviewed some different types of SVT, and we'll review them again in the next upcoming slides. But it's important to understand how the heart normally works. And the heart has a conductor or bus driver or pilot, if you will, and it's called the sinoatrial node. And it's up here at the top left of the screen in the heart's top right chamber called the right atrium. And we want the sinoatrial node or sinus node to conduct regularly and to speed up if we need it to when we're exercising, or to slow down when we're asleep. And that conductor releases an impulse that goes to the center of the heart, where it's then conducted to the bottom chambers. And that normal activation, top part of the heart to the bottom part of the heart through these structures, is what defines normal rhythm. Now, when we say SVT, we're acting like that's one thing or one condition, and it's not. Just like when we say ice cream, we can mean a lot of different things. Are we talking about pistachio? Are we talking about vanilla? Are we talking about strawberry? And SVT has different forms. And so it's always careful when you're talking to other patients to understand that two cases of SVT can be very different from one another and have very different implications. Shown here are two of those different flavors or forms of SVT. One is that video color picture I showed you before, AV node reentrant tachycardia, where the heart's electrical impulse spins around in the center of the heart due to factors in that AV node or connection between the top and bottom chamber of the heart. Another type of SVT occurs because of connections called bypass tracts or extra pathways that connect the top and bottom chamber of the heart. So in patients with AVRT or accessory pathway mediated tachycardia, the electrical impulses can circle through that extra pathway and can also cause SVT. A third common type of SVT is atrial tachycardia, and this is the itchy section of muscle. And instead of the sinus node activating, a different spot of the heart can activate, usually at a much faster rate, between 100 and 200 beats per minute, and it can make the heart go much, much faster. And when these different processes cause the heart rate to get elevated, patients can feel a variety of different symptoms and experiences. They may have the sensation that the heart is racing, like they feel when they're exercising. They may feel a sensation of skipped or extra beats. They can get pounding in the neck or the chest. They can have other discomfort in their chest. They can feel lightheaded, or they can get dizzy. They can lose consciousness, or they could feel shortness of breath because their heart is racing along like they're running a lap around a track, even though they're at rest, sitting still. And again, since a picture can be worth 1,000 or 1,000,000 words, here is someone in the EP lab. And again, the specific words or terms aren't important, but this tracing on the bottom is the blood pressure. And this is being recorded from a catheter in someone's artery. And up top is the EKG. And on the left here, they're in an atrial tachycardia, an SVT, and on the right, they go into normal rhythm. And you can see when they're in the abnormal SVT, their blood pressure drops and returns to normal when they go back into normal rhythm. And so this slide shows that when certain patients go into SVT, their blood pressure drops and their heart is unable to perform as well as it would be when they're in normal rhythm. So we could talk about SVT for days and days and days, but this was just a brief introduction to get everyone oriented. And so I just want to emphasize that SVT is an abnormal heart rhythm that's due to abnormalities in how electricity is conducted and the path along which it's conducted in the top chambers of the heart. Just like many different phenomena in medicine, there are different types of SVT, and the evaluation and treatment of these different types of SVT can vary. The symptoms can also vary, but tend to include a sensation of the heart racing, potentially lightheadedness and shortness of breath, and in some instances, loss of consciousness. And so now we're going to be turning the program over to Dr. Zeitler and Dr. Jackson, who are going to be talking about treatment options, both medication and procedural treatment options for SVT.
Thank you, Dr. Puccini. I'm going to bring up a presentation to talk about some of those topics you just mentioned. And I can really think of no better person to introduce the idea of supraventricular tachycardia than Dr. Puccini. So I'm grateful for that introduction, so I don't have to do the hard part of actually describing the problem. And much like Dr. Puccini did, I'm going to be using the acronym SVT instead of saying supraventricular tachycardia over and over again because my tongue will get tied. So once again, I'm going to be talking about the workup and initial treatment options for SVT. Well, it's not as straightforward as it might sound when we talk about the treatment options for SVT, because in addition to some of the traditional things that we can do in medicine, like use medications or perform procedures, there are also some things we can do before we even get there. Things that might be easier to do, cheaper to do, and safer to do, like looking for reversible causes or learning about some ways to terminate SVT or treat SVT outside of a doctor's office or a hospital. I'm going to go through each of these. But before we talk about the treatments, whether they are more conservative or more aggressive, I'm going to talk about the initial assessment of SVT. So what happens if you think you have SVT or you know you have SVT? You're likely to seek care by your primary care doctor or a cardiologist perhaps, or in some cases, even an electrophysiologist. And the first thing that will probably happen in this initial assessment is to think about what could be causing the SVT that might be fixable, and then the whole problem goes away without any aggressive intervention. And I've listed a couple of those kinds of things here. One thing that might be considered is the presence of abnormalities in electrolytes. And electrolytes are things like magnesium and calcium and sodium. Electrolytes are things that our bodies have to regulate on an ongoing basis all day, every day. And if there's a reason why they might be out of balance, then correcting that balance can sometimes solve the problem of treating SVT. This is somewhat unusual without some sort of underlying medical problem. One of the most common of those is kidney dysfunction or malfunctioning kidneys. This is especially true if the kidneys are very severely diseased, requiring kidney dialysis. But in that case, if there is presence of kidney disease, or even if there's not, there might be another reason why there's electrolyte abnormalities, then addressing that electrolyte abnormality might fix the problem. And this can be identified with some simple lab tests through a blood draw. There are also some endocrine disorders, the most common of which is thyroid disease or thyroid dysfunction. The thyroid is a gland that lives at the base of the neck, and I think of it as the gas pedal of the body. When the thyroid is overactive, or when the gas pedal is being pressed really hard, you can get overactivity, generally speaking, of the body. So a patient with An overactive thyroid might feel hot and sweaty when everyone around them is cold, or they might have trouble sleeping, or they might have a racing heart, and they might have an overactive metabolism, which might result in unintentional weight loss. These are just some examples. And the thyroid dysfunction is not the only way, the only endocrine disorder that can lead to SVT, but it's something that we do think about regularly because it is such a common problem. The thyroid dysfunction can be detected primarily through lab tests as well, through a blood draw, but sometimes thyroid dysfunction is related to abnormalities in the structure of the thyroid, which might be detected through physical exam by palpating around the base of the neck where the thyroid lives. In parallel with an assessment of reversible causes for SVT, your doctor will also consider a diagnostic assessment of the SVT itself. And there are a number of ways that this is done. And some patients might go through all of them and others might not, may only go through one of them. An EKG, Dr. Piccini already mentioned this as sort of the most basic test to be done for SVT. And it is non-invasive, very fast and inexpensive, at least relatively speaking. It requires the placement of electrodes across the chest with a 10-second recording of your heart rhythm. We call these both an EKG and an ECG. It's the same thing. If that's incompletely, does not completely identify the problem, which it very rarely does in the case of SVT, which comes and goes, then an ambulatory monitor might be used. And these come in a number of different flavors. I've just shown pictures of two of them here. To the left is a traditional Holter monitor with electrodes that are also taped or glued to the skin and monitor the heart rhythm for somewhere between 1 to 3 days. A more extended monitor might be like the one you see here, which is a patch monitor. And this can monitor the heart for up to about 2 weeks. And there are others as well that can monitor the heart for longer or shorter periods of time, including some commercial monitors like a KardioMobile or an iWatch, which might have a program to monitor the heart rhythm. In all of these cases, the idea is to try and catch an episode of the SVT in order to make the sort of diagnostic evaluation that Dr. Piccini mentioned, and I will go into a little bit more detail about in a moment. In addition to obtaining information to make a diagnosis of the SVT, to use Dr. Piccini's metaphor, what flavor of SVT it is, it's also a way to evaluate how much SVT there is, how fast or slow the SVT might be, and to correlate it with symptoms. We heard about one of the more severe symptoms from SVT, passing out or syncope. And so wearing a monitor can help correlate when those symptoms occur with episodes of SVT. In addition to monitoring the heart rhythm, your doctor might also want to do some imaging of the heart. The most basic of these, or the most common of these, I should say, is an echocardiogram. And an echocardiogram uses sound waves to make pictures of the heart. And this allows your doctor to assess the structure and function of your heart broadly, including how well the chambers of the heart squeeze, including any evidence of disease of the valves of your heart, as well as the surrounding structures like the lining of the heart called the pericardium and even the aorta. And all of this put together might help your doctor to understand which types of SVT you're most at risk for and what the consequences of SVT might be if there's evidence of other problems with the heart. This is not a painful procedure and is done with just a little bit of cold jelly on the chest. And then there might be a need to perform functional or provocative testing. And the most common of these is a stress test in which you would run on a treadmill or pedal a bicycle, or sometimes a medicine is used to speed up the heart rate to approximate what it's like to exercise. And during that period of exercise or immediately thereafter, there's evaluation of the heart rhythm, oxygen levels, blood pressure, just general assessment of how well the body is working and how well you feel in order to make an assessment of what the risks might be of a rapid heart rate like you might have during SVT, or to look for any underlying problems like a blockage of a coronary artery. Now, in addition to the two buckets of things I've already mentioned, which is an initial assessment or evaluation for reversible causes, as well as testing, there would, in parallel with these two things, there would also be an assessment of identifiable triggers. Now, to be honest, most patients cannot identify an obvious trigger for their SVT, but sometimes there is an obvious trigger which can be avoided. Things like dehydration or alcohol use, sometimes excessive alcohol, but sometimes very modest use of alcohol can be a trigger for SVT. Sleep deprivation, and sometimes caffeine, although that's less common than you might think. These are some of the potentially identifiable and avoidable triggers, which, if avoided, could reduce the burden of SVT. But there are sometimes unavoidable triggers. For example, the hormonal milieu can contribute to SVT. For example, in a pregnant woman, there can be an increase in SVT burden during pregnancy, and that's not really an avoidable trigger. Now, if an SVT episode occurs, if it comes and goes, we call this paroxysmal SVT. And sometimes we can teach patients ways to try and terminate an episode without having to seek care by a doctor or in an emergency room. And one of the most common ways of doing this, we broadly call vagal maneuvers, because it activates the vagus nerve, which connects our brain to our hearts and can help suppress episodes of SVT. One way of doing that is to turn a syringe other way around and blow into the narrow end. And this causes the patient to bear down, and it's this bearing down action which activates that vagus nerve. Can also close your nose and breathe hard against your closed lips, and this achieves the same outcome. The carotid artery is an artery that runs through on both sides of the neck, and if rubbed, can activate a sensor which can help terminate an episode of SVT. This is not something that we generally recommend that patients do, but if you seek care in an emergency room or in your doctor's office, this might be a maneuver that's performed to try and terminate an episode of SVT. Dr. Jackson, who will be following me here in just a moment, is going to spend much more time talking about therapeutic interventions, which largely fall into two buckets of drugs and invasive therapy. So I won't spend a whole lot of time talking about this, but I'll mention them because these are some of the most aggressive ways and some of the most effective ways we have to reduce the burden of SVT or suppress episodes. And medicines can be used as needed or taken regularly. And as I mentioned, Dr. Jackson will spend much more time talking about drugs and interventional procedures. But I will piggyback off of what Dr. Piccini also said about the right intervention, depending largely on what type of SVT we're dealing with. Now, we already heard about the metaphor of ice cream, and which I think I like a whole lot better, although maybe that's because it's lunchtime and I haven't eaten yet. But I often use the metaphor of a vehicle when we talk about SVT. SVT is this big, broad umbrella of things, and we have to drill down to figure out what type of SVT it is in order to counsel patients about the balance of risks and benefits for intervention and the most likely effective intervention. So if you're talking about a vehicle, is it a car or a truck? Is it a sports car, a sedan, an SUV? And if it's a sedan, is it automatic or manual? And if it's automatic, is it 4-door or 2-door? You get the idea. There are a lot of ways to be increasingly specific about the type of SVT, and that's important in order to select the right treatment strategy. Now, I've talked a little bit about SVT that comes and goes, but if an SVT episode occurs and doesn't terminate on its own, or you're unable to terminate it with one of the maneuvers we've talked about, then you are likely to seek care in a clinic or hospital. This often takes place in the emergency department, especially if you experience one of the more severe symptoms of SVT, like passing out or syncope. In that case, when you arrive, the very first thing that the physician or nurse practitioner or the whoever is evaluating you, one of the first things they'll do is assess whether you are stable or unstable. And this is largely based on your blood pressure. If your blood pressure is unstable, or if you're generally unstable, there will be a cardioversion right away. And a cardioversion is using electricity to reset the heart rhythm. And this is typically done after delivering some sort of medicine to help reduce the sensation of the cardioversion. But for patients who are very unstable, there may not be time for that. In patients who are stable, meaning they may not feel very well at all, but are able to talk and are not having a collapse of their blood pressure, then other sorts of interventions will be tried first. If the patient is very stable, then vagal maneuvers like the ones I've already described might be tried first, since these have very low risks associated with them. An emergency room doctor, for example, might coach you through how to perform one of these maneuvers to help terminate the episode. If that doesn't work, one of the most common interventions is a drug called adenosine. Adenosine is delivered through an IV that's placed usually in your hand or arm, and a small dose is administered through that IV. What adenosine does is, very briefly, it terminates electrical conduction through the normal electrical system of the heart. I've highlighted in this red bar here on this EKG, and it's not important to know what's going on in this EKG, except in that red bar, you see there is no heartbeat there. And that's because adenosine was administered. It's a very brief event, but it can make you feel really, really unwell. It can be very scary. And so it is ideal for the person administering the drug to warn you that it's going to feel very unpleasant, but for a very short amount of time. The drug is gone out of your system within a few seconds. And certainly if none of that works, then you may experience a cardioversion. Now, this is different than for an unstable patient who needs to be cardioverted right away. If some of the more conservative measures like IV adenosine or vagal maneuvers don't work in a stable patient, then you would receive medications to help relax you and put you to sleep before the delivery of a cardioversion, which again is electrical energy to reset the heart rhythm. Now, for a patient who has frequent episodes of SVT, or the episodes are very severe, then there will be a more aggressive intervention using drugs or ablation. And again, I'll leave this to my expert colleague, Dr. Jackson, to go into more detail. Finally, I'd like to address the question of whether infrequent symptoms really require treatment. And the answer, much like other areas of medicine, is that it depends. It really depends on a number of factors. And I just listed a few of the factors which often come into play when I'm discussing with my patients who have SVT about whether to do anything. And if we do something, what should that something be? It really depends on consideration of these factors and perhaps others that I didn't think of. For example, SVT type. There can be variable response to treatments depending on SVT type. Some are highly amenable to interventional treatment like ablation, in which case it might make sense to proceed directly to ablation in order to eliminate the problem. In other cases, ablation is not a very effective therapy, and the risks might not be outweighed by the potential benefits. We also consider very seriously the side effect profile of these interventions and the weighing of risks and benefits, as well as symptom severity and symptom frequency. If episodes of SVT occur once every 5 years, then doing something invasive may not be worth the risks. It might be better to simply weather the storm that only happens once every 5 years, instead of putting oneself in harm's way, even if those risks are pretty low. And also, I'll mention the potential effectiveness of conservative measures. For example, if you identify that the only trigger for SVT is alcohol consumption, for example, then it might be reasonable for some patients to simply avoid the trigger, simply avoid alcohol. And that won't be acceptable to all patients, depending on what the trigger is and how severe. Thought of this in a different way, I like to put the idea of risks and benefits on a scale. On the one hand, we have risks of treatment. On the other hand, we have the quality of life if we don't intervene. And I call that sort of strategy a surveillance strategy. On the one hand, when we think about risks, we have to consider some of the things I already mentioned, which are SVT type. What are the risks of ablation versus drug and the potential expected benefits of that? And then the side effect and complication profile. These may or may not be acceptable when balanced against the benefits of an intervention. And on the other side of the scale, what is the symptom severity and frequency? Perhaps these don't justify an intervention, but perhaps they do. And then, as I also mentioned previously, the effectiveness of conservative measures. If we can identify a very effective conservative management strategy, that might be preferable over the use of drugs or ablation, or it might be preferable as a first try. So trying conservative measures and seeing what happens. If it's incompletely effective or unacceptably effective, then we can proceed to more aggressive interventions, again, that Dr. Jackson will review with us more carefully. Thanks very much.
Thanks for that fantastic review, Dr. Zeitler. We're going to have Dr. Jackson guide us through procedures, including the EP study and catheter ablation, and then we'll get to answering questions and having a great discussion.
Thank you, Dr. Piccini and Dr. Zeitler, for your excellent discussions. A special thank you to the leadership of the Arrhythmia Alliance, as well as your viewership for the opportunity to speak here today. As we begin to discuss the treatments for the management of supraventricular tachycardia, I will also abbreviate that to say SVT. Let's focus on two entities, specifically pharmacologic therapy and procedural-based therapy. Now, with respect to pharmacologic therapy, we have short-acting medications for the treatment of SVT that typically affect a very unique area of the heart's electrical system called the atrioventricular node, or AV node. Now, as awe-inspiring Dr. Piccini has already articulated, the AV node functions as a gatekeeper, so to speak, processing signals, eventually moving them toward the ventricle, but it functions as a check or a toll booth for the whole heart's electrical system. So examples of these short-acting medications include beta blockers, such as metoprolol, calcium channel blockers, such as diltiazem, and the old digoxin, which does play a role in the management of SVT. Most of these medications are administered daily, specifically for those who have a high burden of symptoms, but they can be used on an as-needed basis for those with short symptoms or intermittent symptoms that are of mild or moderate intensity. And while these medicines, these AV nodal blockers, so to speak, are generally well tolerated, they do present inconsistent efficacy in suppressing the symptoms that may be associated with supraventricular tachycardia. With respect to additional pharmacologic therapy, let's focus on the rhythm stabilizing medications called antiarrhythmic drugs. Antiarrhythmic drugs tend to focus on the various proteins on the cardiac muscle and regulate the movement of various electrolytes, such as sodium, such as calcium, and such as potassium. We have notable examples of antiarrhythmic drugs, including flecainide, including propafenone, including sotalol, and including amiodarone. These medications are typically administered daily with the potential for multiple doses per day and typically have a longer onset of action than those shorter acting medications, including the metoprolols and the diltiazems. And while antiarrhythmic drugs generally have a more consistent efficacy in suppressing symptoms associated with SVT, we should understand that there are notable precautions as well as interactions associated with antiarrhythmic drug therapy. And these precautions and interactions can lead to very demonstrative side effects, including organ dysfunction. So why would somebody elect for medical therapy as opposed to procedural-based therapy, which we will speak to shortly? Maybe somebody just has infrequent symptoms. Their symptoms are intermittent, they're very sort of short in duration, and maybe a short-acting medicine is really all they need, or even an antiarrhythmic drug is all they need to keep their symptoms at bay. Maybe a particular patient is risk averse with respect to undergoing a procedure such as catheter ablation. They've spoken to their heart rhythm specialists. They've reviewed the risk and benefits of both pharmacologic therapy, short-acting, long-acting, procedural-based therapy, and they're just not comfortable with the risk associated with an invasive procedure. There may be anesthesia considerations. A patient may have had a prior bad reaction with some element of the anesthetic process. The patient may have an inability to lie flat for 3 or 4 hours. Sometimes that is needed to treat a supraventricular tachycardia. So we have to consider anesthesia and its potential role and whether a patient would elect for medical therapy versus a procedural-based therapy. And as the fantastic Dr. Zeitler articulated, it all comes down to patient preferences and clinical appropriateness. What does the patient prefer? What does the patient value with his or her medical care? How do they make an informed based decision? And part of that process will generally lead a patient to select a therapy that is right for him or her. Just to review the acute medical treatment for SVT, Dr. Zeitler has presented some of this information. We have vagal maneuvers, but with respect to pharmacologic interventions, we have intravenous therapies such as adenosine, short-acting, quickly can terminate SVTs, specifically those that depend on the atrioventricular node for propagation, as well as intravenous beta blockers and calcium channel blockers that affect the AV node in such a way that they may not only slow the rate with respect to an SVT, but also terminate it due to its effects, once again, on the atrioventricular or AV node. For ongoing or chronic medical therapy for supraventricular tachycardia, here's where those rhythm stabilizing or antiarrhythmic drugs tend to come into play. More of the flecainides and the class 1As, including propafenone. If there's an absence of structural heart disease, we have even potentially stronger second-line agents, such as amiodarone, sotalol, and dofetilide, that while effective, have those notable precautions and potentially interactions that must be taken into account on an individual patient-by-patient basis. So let's talk specifically about catheter ablation. So what is catheter ablation? Catheter ablation is typically combined with an electrophysiology study, which we will sort of review. It is an interventional-based technique that aims to destroy heart cells that are responsible for causing SVT. Yes, audience, we are destroying heart cells. We're not doing that in some haphazard fashion, but we are in a very focal and a very selective manner aiming to destroy these cells that are causing your abnormal heart rhythm, specifically SVT. I must emphasize that this is a non-surgical based technique. I will repeat, this is a non-surgical technique. We are not opening the chest cavity to expose the heart. We are using an interventional based procedure using the veins in the groins primarily to access blood vessels and access the heart. The catheters that I am speaking about use either extreme heat or extreme cold to destroy areas in the heart that are leading to problems and causing your SVT. And in addition to fancy catheters that can blast heart tissue, we do use fancy imaging, x-rays, and other imaging techniques that not only assist us in gaining access to the femoral veins, but they really do make your procedure more efficient and safer. So here are just a couple of figures that are representative to show you kind of like, give you an idea of what we're doing during ablation. The figure on the bottom left shows a catheter that is touching the heart tissue. You see some electrodes on that catheter that have the ability to sense the heart's electrical signal. And through a process of what we call resistive heating, almost friction, that catheter has the ability to transmit energy to the heart tissue and effectively kill those cells that are underneath that catheter tip. The image on the upper right shows a cryoballoon. It is actually touching heart tissue, and through the process of freezing, but in a different way than resistive heating, we can affect damage and in a very focal manner, injure and kill cells that are causing your abnormal heart rhythm. So how is our catheter ablation performed? So you must remember that generally catheter ablation is combined with an electrophysiology study. So during an electrophysiology study, we have specific catheters that are inserted to the heart, and they are placed in certain locations, particularly the right atrium, the His bundle AV node region, the coronary sinus, as well as the right ventricle. And all these catheters have the ability to record electrical signals and make measurements of electrical conduction that are very important to the process of a general electrophysiology study. In addition, these catheters can also send electrical signals to the heart, causing it to stimulate, causing it to contract. And it is that very stimulation and contraction, sometimes at very fast heart rates, that is needed to potentially induce or bring out your abnormal heart rhythm. Once we bring out your abnormal heart rhythm, we can diagnose it. And once we've diagnosed it and deemed that it is in a safe location, we can use other catheters that can either heat that abnormal focus or apply extreme cold to that abnormal focus, okay? And we do this all with the aid of fancy mapping systems called three-dimensional mapping systems. Here is a diagram of a three-dimensional mapping system. We have a geometric display here specifically of the left atrium. Our abnormal heart rhythm is on the left-hand panel with an EKG, and also EKGs from actually inside of the heart from those catheters that we strategically place at different positions. And what you can see is that with the aid of this 3D mapping system, we've generated essentially a heat or a location map of exactly where our abnormal heart rhythm is occurring. In this case, it's an atrial tachycardia, and we are poised to place energy in that direct spot, which will hopefully lead to termination of this abnormal focus. So what are those indications for catheter ablation? Well, we spoke about fancy medicines, both short-acting, long-acting, some with mild side effects, some with more side effects that are available to treat our supraventricular tachycardia. But these medicines can cause side effects, and sometimes they can just be ineffective at controlling the specific symptoms that are really driving us crazy from this SVT. What do we know about catheter ablation? Boy, it can be curative. And we'll see on the next slide that acute success rates are greater than 90%. What else can it do? It can provide immediate relief of those symptoms that are really just causing us so much stress and potential anxiety. Symptoms such as palpitations, symptoms such as shortness of breath, chest pain, chest pressure, lightheadedness, dizziness, even passing out. Catheter ablation has the ability to remediate all of those, okay? But we also remember catheter ablation may not be indicated for everybody, specifically those people who have infrequent symptoms or are just not willing to tolerate the risk associated with catheter ablation. As we spoke earlier on the last slide about success rates, most success rates for catheter ablation acutely, meaning in the short term, are greater than 90%. We have data here from the guidelines that demonstrates for atrioventricular nodal reentrant tachycardia, the acute success rate is about 96% with a 5% recurrence rate. And you can see the overall complication rate for an ablation associated with AV and RT. For atrioventricular reciprocating tachycardia, tachycardia using an accessory pathway or an accessory connection, we can see that the success rate is still very good, 93% with a little bit higher recurrence rate an equal rate of complications. When we speak about complications, we must be honest with our patients. That is the process of informing them so that they can make an informed values-based decision. And they should understand, while they may hear about a lot of potential bad complications, bleeding, stroke, heart damage, bleeding around the sac or within the sac of the heart, damage to the lung tissue, the risk of these potential complications is exceedingly low. And I want the viewership to understand that catheter ablation combined with an electrophysiology study is a very well-tolerated procedure. It's something that we do commonly. And once again, has the opportunity to afford quick success in elimination of symptoms. So in summary, I think the other speakers have articulated some epidemiologic evidence, some workup of SVT, but my role is to tell you that we have options, both pharmacologic versus procedural, and the option you choose depends on your level of risk, how informed you are, and your degree and intensity of symptoms that you may have. So with that, I will stop my part of this presentation to turn it back to Judy and Dr. Jobs-Cheatham.
First of all, I want to say thank you on behalf of all the patients for making it so clear and easily understood. What is SVT, living with SVT, treatment options for SVT, etc. All too frequently, Dr. Pasini, because of the sensation of the rapid heart rate, the pounding out of the chest, it makes someone feel very anxious, very stressed, and feel that SVT is dangerous. How would you address that?
Yeah, and first, before I answer the question, and I hate the first thing I do is avoid answering the question, but I just want to emphasize that we're in a very time-pressured society, especially in our medical clinics. So I really want to thank Dr. Jackson and Dr. Zeitler for such a thorough, patient-centered description of, the options for SVT. And there's no way in a busy clinic session that that we could possibly go into that great detail. And so I hope everyone finds the time they shared with us to be very valuable. I certainly picked up a few things of my own to help me explain things to my patients better. So I hope all the patients and families found it as useful as I did. So yes, so the sensation is very jarring. And I think that came out both in Dr. Jackson and Dr. Zeitler's presentations, that it can be very traumatic for patients. The really good news is that SVT is very, very rarely fatal. And yes, it's true. If you pass out and you're on top of your roof of your house, yes, that could potentially be a fatal event. But by and large, while the symptoms are very scary, it is not something that typically leads to fatality. And so, and highlighting, it's a very, very treatable condition, among the most treatable conditions we have in heart rhythm medicine. And so it's very easy to say, don't be anxious. And certainly that's not what we're saying, because if you're feeling unwell, you need to get treated so we can get you feeling better. But folks should not lie awake at the ceiling, worried about dropping dead. When we evaluate patients for SVT, part of that evaluation is to check and make sure there's not other things wrong with the heart that we do need to be concerned about.
Thank you. And, most people it's the anxiety and coping with the anxiety. Dr. Zeitler, do you have any tips or things that, to calm that anxiety when they're experiencing an episode of SVT?
That's a great question, because just like Dr. Pasini just said, it doesn't matter if we say that it's not dangerous. That doesn't always help the anxiety, because the anxiety is there and patients feel how they feel. I would say that I have found that some patients, just through education about the very low risk associated with SVT, that can be helpful in addressing some of the anxiety. knowledge, I mean, knowledge is power. And so when we educate our patients, and as you know, as viewers of this session will know, educating themselves, that can often help address the anxiety, but that's not always sufficient. There can be this very sort of dangerous self-fulfilling prophecy of anxiety, sometimes even being a trigger for the SVT, and then the SVT increases the heart rate, which increases the anxiety, and around and around and around. So sometimes it's just direct treatment of the SVT is necessary to eliminate the problem and the SVT altogether. If I have a moment, I have a story of a patient who was having just terrific amount of SVT, and for most of her life was told that it was a panic disorder, because she just had a tremendous amount of anxiety associated with it. It wasn't until she was in her 5th decade of life that she was ultimately diagnosed with honest to goodness SVT, that she and I both suspected was really the true cause of her anxiety. And after the procedure, which was a very straightforward and effective curative ablation treatment of her SVT, as she awoke from anesthesia, she looked at me and I said, "How are you feeling?" And she said, "I feel really weird." And I said, "Oh no, something wrong. You know, I thought there might be a complication from the procedure, which had gone really well." And she said, "No, I'm not having a panic attack. And this is a pretty scary thing that I just did. And I can't believe I'm not having a panic attack." And it was at that moment we realized that it really was the SVT all along. So sometimes I think it's just treatment of the SVT itself that is really necessary to address the anxiety. It's very rare that patients, I think, need actual medical therapy for the anxiety, meaning, you know, an anti-anxiety medicine. Although I have seen that from time to time, it can be helpful so that a patient can then be more calmly approach their options for treatment of the SVT if we address the anxiety to help them think more clearly about their options.
Thank you. Yeah, we are hoping that from this series of Living with SVT, it will empower patients to better understand and to engage with their clinicians. But for many, it's getting to see a clinician that specializes in heart rhythm disorders and SVT, because all too often they don't get that far. So between you, what do you think the tips are that the patient should be asking? You know, is it anxiety? Is it something to do with my heart? What should they do to be able to access experts like yourself? Larry, do you want to lead on this one?
Yeah, and I think to Dr. Zeitler's point, and you know, we should never minimize symptoms, and the patient. It's all about the patient getting to the right level of care, but really getting the appropriate workup, right? Not blowing off symptoms, and really understanding from a historical standpoint what the patient is going through, understanding the frequency of potential symptoms. And hey, maybe this is something different. Maybe this is something in the cardiac realm and the abnormal heart rhythm realm that needs attention. And taking that history, performing an appropriate workup, and then potentially, exacting a potential therapy that may be helpful for the patient. I think patients, really, at least the patients I see, are really empowered. And I've had many with the same sort of story as Dr. Zeitler self-refer themselves into my clinic. Hey, I'm not getting the workup, the attention to my problem. I'm having anxiety, but I'm also having palpitations. I'm seeking you out to help expand on the workup, but really think about things differently. So I think patients have to be empowered. Hey, we have physicians here for second opinions. Seek us out, and really begin the discussion to see if your symptoms are related to something that's related to an abnormal heart rhythm.
And I would add to that, Dr. Jackson, that I totally agree with you that one of the more empowering tools available to our patients now are the commercially available monitors, which I mentioned briefly during my slides. These are things that many of them are very inexpensive and very easy to use, even for patients who are not very technologically savvy. And some of the algorithms that are used by these devices to analyze the heart rhythm are getting better and better. And I have had many patients arrive in my clinic, either self-referred or otherwise, after one of these commercial devices has truly already made the diagnosis of SVT. So it is another way to empower patients both before and after they have a consultation. So especially if the episodes are infrequent, then monitoring for some patients can be very helpful in managing the anxiety and understanding how much SVT they're actually having. Other patients, it can actually increase the anxiety. So we have to be careful about it, but they can be very empowering.
And Dr. Piccini.
Yeah, I think, there's been a lot of really good points here. I want to raise one more, and then I want to ask a question of Dr. Jackson and Dr. Zeitler, a question that gets asked of me in clinic, and I always feel uncomfortable answering it. So I'd like to hear what they have to say. But I'll just say with the monitoring devices, all too often, I think for our patients with chronic heart rhythm disorders like atrial fibrillation or PVCs, the monitoring devices can sometimes can be a problem because they can lead people to continually be checking their heart rhythm, even though they very well know what their own symptoms are. I think any unknown heart rhythm disorder that's very intermittent, where a patient can actually capture what their rhythm is during the time of their symptoms, that's where these commercially available devices have the greatest value. And so, I completely, agree and would emphasize that those devices can serve a really valuable role here. I think as I was listening to both Dr. Zeitler and Dr. Jackson, it highlighted again that if there's one theme that we've all emphasized the most, it's that every patient has a different experience and that each individual needs to weigh how much their symptoms affect them or how much the fear of having an episode affects them versus how they feel about the risks of each treatment. And the most common question I get asked in clinic, which I refuse to answer, is, Doc, what would you do if you were me? And I think that's really hard because it's very presumptuous for me to pretend I know what it's like to be afraid to walk on an airplane because of SVT. On the other hand, there are some patients that have very mild symptoms. And so I don't also want to exaggerate someone's symptoms in my mind. The patient is in the best, position to weigh those things. So Dr. Jackson, Dr. Zeitler, when someone says, Doc, what would you do if you were in my shoes? How do you handle that? And what advice do you give to the patients?
Dr. Piccini, I'll start off and thank you for the question. I am very frank and honest with patients that I am not necessarily here to make decisions for you, but I am certainly here to help inform you and help make so that we can make a decision together. And I view my role as that of being sort of an expert in abnormal heart rhythm. So what does that mean? I can tell you the benefits of pharmacologic therapy and tell you the benefits of procedural therapy, but also tell you the risks. And that's my expertise. But then I want to hear from the patient. What is your expertise? What do you value with your treatment? What do you prefer with that treatment? And I think collectively, hopefully, that the patient and I can come to some sort of decision in a shared fashion about what is best for them in terms of a therapeutic option for treating that SVT. So I try to stay away from putting myself in the position of what I would do for my mother or my father or a sibling or even myself, and really individualize it toward the patient.
Yeah, I would agree with all of that. And I would say two additional things to your question, John, which, we all get it basically every consultation for SVT, we get asked this question. And I would say two additional things. Number one, hopefully that question has come towards the end of the visit when we've gone through all of the options. And so I assume that the question really is, the patient is saying, based on what I think is important, what should I do? And so I turn it around and I say, well, what I hear you saying is that X, Y, and Z are important to you, and A, B, and C are less important to you. And so let's think about how to balance those things. And sometimes that's helpful to turn the question back around and get the patient talking more about their priorities so that they can make that assessment on their own. Because like both of you had said, it's not up to us. The second thing is, just as you said, Dr. Piccini, we don't, it's very presumptuous to try and answer that question. We get, in best case, we get to know a patient for about a half an hour. We can't possibly help them answer that question definitively. And so I remind them this is not an emergency. And I say, let's plan not to make a decision today. Why don't you go home and talk with your family? They know you. They can tell you what they think you should do, or they can help you think through that. And then let's have a follow-up phone conversation. I find that to be really helpful, even if they don't talk to anybody else, just sleeping on it or living with their SVT and sort of thinking to themselves, well, what would this SVT feel like if I knew I was having ablation next week, or if I knew that I was going to start a medicine next week? And that can help them sort of balance those risks and benefits again in their head without me, without the clock ticking on our visit.
Yeah, great advice. Never make an important medical decision at the end of a rushed clinic visit. For anyone out there, if you are on the fence, the right answer is always to say, I think I'm going to talk to my family and discuss this with them before we make a final decision. Great advice. Thank you both for that.
I think that's fantastic advice. Absolutely. We're often asked by female sufferers of SVT whether there's any connection to hormones. Does that have any impact on their episodes of SVT? Who would like to take that one?
I'll take that one. I think I should take that one. So I don't put my colleagues in an uncomfortable situation. So the answer is yes. Hormones can absolutely have an impact on SVT burden. And there are true impacts of hormones on the way the electrical system in the heart works. I'm not sure it's helpful or useful to go into detail about how this works at a cellular level, but it's absolutely true that the dominant hormones involved in the menstrual cycle, for example, progesterone and estrogen, absolutely do have an impact on the way electricity works in our hearts. But the answer is, as you might anticipate, is far more complicated than that, because there can be associated other factors associated with hormonal cycles, dehydration, pregnancy, which I mentioned, or sleep deprivation, or even the surges of energy or surges of catecholamines or stress hormones associated with pain that might accompany menstruation, for example. This is a very complicated interplay. And so it is really unpredictable how hormonal changes will impact what actually happens in terms of SVT. I've absolutely had patients who have a known history of SVT and become pregnant and have severe exacerbations of their SVT and actually require treatment during pregnancy that they never required prior to pregnancy. But the converse is also true. Patients with significant burden of SVT who become pregnant, and then it goes into remission during their pregnancy. So unfortunately, there's not a straightforward answer. But I would encourage your viewers, certainly women, since you asked it that way, I would encourage women to be mindful of how changes in the hormonal cycle seems to impact their burden or severity of SVT, because that can be helpful in thinking about reversible causes, which I mentioned, but also ways to treat it, which take that into consideration, and also help in the consultation, especially for a young woman who might be doing some family planning, understanding when the right time is to intervene on an SVT and what you didn't ask me this question, but I'll also say that some medicines that Dr. Jackson talked about are completely not appropriate in the setting of pregnancy, and others really are. And so there might need to be some medication adjustments in that setting. So it depends is the answer, like most things in medicine.
Thank you.
There's two things there I think are worth emphasizing. So, I think Dr. Zattler is also making a call to all patients to think carefully about what things either trigger or are associated with their abnormal rhythm. And so visits are so valuable. And again, in this time crunch that we're all in, a really useful exercise before you go in for your consultative visit is to record when you have episodes in a diary. And you may observe some patterns that will be really valuable for your physician or healthcare provider to know about. So I think that's one really important element there. And another is the importance of family planning. And so even in a young woman who has extremely well-controlled SVT with a management strategy that has worked for years for that individual, if someone with SVT is thinking about getting pregnant and starting a family, it often can be very valuable to have a touch base visit with their electrophysiologist, just so the interventions can be revisited. And if there's no change in the plan, also discuss, okay, second trimester, you go into SVT. What are we going to do together? How are you going to let me know about that? What are we going to do? Are you going to go to the emergency room? If it's an emergency, that's obvious, but it might be a good idea even in the absence of severe symptoms, depending upon where someone is. So two huge points that have been raised there and worth of emphasis.
Thank you. Some really great suggestions. No wonder you're SVT pioneers with all that you're saying. I know, Sam, you've been receiving questions as well from the patients and caregivers that have registered. So I'll hand over to you.
This one was concerning a failed ablation. The patient during an ablation was put completely out, and so they couldn't trigger the SVT. And so the ablation failed. His question is, would having another one but being awake help?
Yeah, I think that's a great question, and probably be helpful to know a little bit more detail. But sometimes when you present for an electrophysiology study, we have to remember that our first goal is to study the heart electrically and also induce the arrhythmia. If that is successful, then we can proceed. If we feel like the SVT has been, documented and diagnosed and deemed to be safe, then we can proceed to ablation, right? And so sometimes, infrequently, we don't want this to happen, that you just can't induce somebody's abnormal heart rhythm on the day of procedure. And your patient is very wise that the level of anesthesia and, how deep somebody is sedated can play a role into that. But I've certainly had patients where I've had to bring them back, not only a second time, but potentially even a third time. We've had to consider things like sleep deprivation and waking them up during the procedure. But ultimately, we were able to be successful in not only inducing their abnormal heart rhythm, but treating it. So it can take more than one trip. You do have the potential to plan for different anesthesia considerations. But it's a great question. And I think, sometimes a little bit of persistence with SVT, even in the context of an EP study that wasn't successful once, is worth pursuing a second round.
Thank you.
Dr. Jackson has dropped a true pearl there. So there's two things that sleep deprivation loves: Freddy Krueger and arrhythmias. So, if you have a history of your doctor not being able to induce you, or if you have an arrhythmia that is prone to that, your doctor may tell you, try not to go to bed the night before, or stay up all night and binge movies. And that is a pro's tip. And so your doctor may ask you about that. Again, wonderful insights and lots of fantastic tips here for everybody.
Are there other things that a patient could do that typically trigger an SVT that might help them on the day of an ablation? I know it's hard to drink coffee right before or have any stimulants, but if that's something that could trigger, is that something that they, in worst case scenarios, that's something that would work for them?
I think it depends a lot on the patient, and it gets back to what Dr. Jackson and Dr. Puccini were saying about the case where you have identified triggers, and a little bit of what I presented earlier, that when there are identifiable triggers, for SVT, you want to try and approximate that as best as possible leading up to the procedure, because if you can't induce SVT, then the ablation is not probably going to be very productive. So, in fact, you can drink, at least depending on the institution, you often can drink some coffee before procedure or a few hours before, as long as you don't put any milk in it or cream, or you don't tell anybody. And so, you can do these things. I mean, you probably don't want to show up drunk to your SVT ablation, but if you get really desperate, that you might do some of those things. And we also have some tricks up our sleeve. During the procedure, we can infuse artificial forms of this. So we can infuse artificial forms of stress hormones, like we call it, artificial adrenaline. We can give through an IV. We can even give IV caffeine during a procedure. And so before we give up, I know I speak for my colleagues when I say this, we don't give up easily. And so before we give up, we'll try all kinds of things to try and rev up the engines that run SVT. But, whoever, the person asking this question is absolutely right that sometimes the SVT ablation procedure is just such an artificial experience, laying flat on your back for hours. It's just hard to recreate the life scenarios that seem to trigger SVT. But we do try these tricks, and we can counsel patients leading up to it to do everything they can, to try and flip all the switches that turn on their SVT leading up to the procedure as safely as possible.
Thank you. A question that comes up time and time again: is it safe to drive? When should I not drive? What happens if I'm driving and suddenly an SVT episode occurs? Should I pull over? Should I, what should I do? Who would like to take this one? Dr. Pasini?
Yeah, sure. I think this is a really, really hard one. And I'm just going to upfront say that I think heart rhythm doctors themselves have some healthy debate about this. Let me start at one end. Who should definitely not drive? People who have SVT, who have symptoms at the drop of a dime and go from feeling completely well to feeling almost close to passing out with very little warning, those people should not be driving. And I think the reason is obvious. If they were to develop an episode of SVT, they could lose control of their vehicle. On the other hand, people who have a sensation of palpations but have never felt lightheaded, have never even remotely felt close to passing out, and they don't feel great in SVT, but they can continue to work and do those things, those patients don't have to worry about not driving. In between, there's some gray zones. So as long as someone has several seconds or minutes to pull over, then you probably don't need to caution them against driving. That is some general guidance. But again, like a lot of things we've discussed today, discussion with your individual physician is of paramount importance.
Dr. Seitler, would you agree?
Are you asking if I'm disagreeing with Dr. Pasini?
No.
Oh, please do.
Agree
Please
with
do.
Dr. Pasini.
No, I do actually wholeheartedly agree with that. I mean, I'm sure you're asking the question because most patients fall in the gray zone. So, when they, as Dr. Pasini described, if they really shouldn't be driving, that tends to be obvious. Although I will add that, again, I know I speak for my colleagues when I say that we do not take that lightly. And I work in a rural area where driving is livelihood. Patients simply cannot get to work or the grocery store or their doctor's visits for that matter without driving. So when we take that, in my state, I don't actually confiscate the driver's license, but in other states that is the case. So when I make the recommendation for patients to stop driving, I do not take it lightly. And oftentimes, in the rare cases when I do make that recommendation, I do it, I ask the patient to bring a family member with them or get somebody on the phone to come up with a plan. Because you need to have a transportation plan if we're going to take away or make the recommendation to stop driving, because it can be really a dramatic change to lifestyle and it can be unsafe for some patients.
And Dr. Jackson, do you have anything to add with driving and SVT?
No, I tend to agree with both of my colleagues, and I like the way Dr. Pasini sort of focused on spectrums of disease. And, unfortunately, I had a patient, her real first presentation of anything cardiac related, she was a youngish patient, was a terrible motor vehicle accident. And all she could remember before that was that, something was not right for her heart. And long story short, she had an accessory pathway moving at about 290 beats per minute, which, putting things together probably led to our car accident. But I tend to agree that, it's a tough situation sometimes for people to be in, specifically people who have rapid sort of ultra sensitive symptoms. And, our guidance around that is just being thoughtful of the greater sort of population at hand, specifically those with potentially dangerous and fast and very symptomatic SVT.
I'm also really happy that the subject of livelihood has come up again. And, so here's an example where if someone can't drive, for many people, that means livelihood. And that is something that needs to go into the equation of what treatment is optimal for someone and what risk we're willing to tolerate. I think for the vast majority of patients with SVT, you should not need to worry about your livelihood from SVT. Of course, there are some exceptions to that, but again, a treatment plan should be able to accommodate the vast majority of individuals and get everyone back to work safely.
Sam, I think you have another question.
This is from another patient concerned about his blood pressure. He noticed that when he's having an attack, his systolic often goes up to 180, and it reduces fairly quickly within half an hour, but he's just concerned that this is uncommon. So is this a typical symptom?
Yeah, no, it sounds like what happens is when this gentleman goes in the SVT, his body notices and he dumps a lot of adrenaline into his bloodstream, and part of his nervous system gets involved and delivers more sympathetic output, and that drives his blood pressure very high. And usually patients with SVT have symptoms because the blood pressure gets low. But there are patients who have high blood pressure. When they get SVT, their blood pressure can get so high that it becomes life-threatening. So this question is another great example that every case of SVT is different, and the details matter and the treatment plan matters. So there's a situation where, not only does the patient have to deal with the symptoms of SVT, they potentially have to deal with the side effect of a dangerously high blood pressure during the episodes.
Thank you. Dr. Jackson, lots about sport and exercise. Can they continue with exercise? Can they participate in sport when they know they suffer with SVT, or when should they continue with exercise if they go into an SVT episode?
Yeah, it's a great question. And some of this, once again, just has to be individualized to the patient, and recognizing, I think all of us would say, sometimes exercise has been a trigger for some people's SVT. And so it all depends on symptom burden, intensity of symptoms. I have people who can rapidly perform vagal maneuvers and continue playing soccer. I've heard that story. I've had somebody so symptomatic being triggered from exertion that they've had to stop. And once again, these are the type of lifestyle things that really sort of affect patient preferences and values and really management. So I don't think there's a single straight answer, Trudy. I think it just depends on the individual, their burden of symptoms, their intensity of symptoms, what kind of exercise they're actually doing, and really how that is potentially affecting their quality of life.
I would totally agree with that. And I would add that sometimes the best advice is just to listen to your body. And if you're playing soccer and you have an episode of SVT and you feel okay, like you can keep playing, then you're probably fine to keep playing. But if you're feeling lightheaded and weak or short of breath, then you probably should stop. So, SVT is, as we've heard repeatedly during the session, SVT is very rarely dangerous, but it can be very uncomfortable. And certainly, if we try to push through it, you know, I always tell my patients not to be a hero. You try and push through it, you can take a situation that's not dangerous and make it dangerous by putting yourself in harm's way by not listening to your body. So I totally agree with what Dr. Jackson said. And in most cases, you know, it's not dangerous for patients with SVT to engage in whatever activities they would like. And in many cases, especially young people who are engaged in more competitive athletics, that actually treating the SVT will improve their ability to participate, will make it, you know, reduce the symptom burden or eliminate the SVT such that it's not something that holds them back in their athletic pursuits.
Thank you. And for our younger viewers or parents that may be watching, what is the youngest age that someone may develop SVT? Can you be born with SVT? Maybe Dr. Pacini?
Yeah, so I think here's an area where Dr. Jackson, Dr. Zeitler, and I would all agree. None of us are pediatric cardiac electrophysiologists. And so there is some intrinsic discomfort when we start to begin to discuss individuals less than 18 years of age. But yes, tragically, there are forms of SVT that can affect infants even before delivery. And some of those situations can be quite dire. Literally, this disorder can present at any age of life. And if you are a parent and you think your child has SVT and you're concerned that it may not being evaluated fully, then seeking out a heart specialist for children is of paramount importance.
Thank you. And then when or should I tell my workplace that I have a heart rhythm condition such as SVT? Is it something I should disclose? Maybe Dr. Zeitler?
Sure. Gosh, that's a big question. And it has so much to do with all the other topics we've discussed today about, you know, the severity of symptoms, but also about what kind of workplace it is. And unfortunately, I think we can all agree that there are some workplaces that would be more helpful than others when disclosing an important piece of health information. I think when there is a concern that an episode of SVT could be life-threatening or could require medical attention, even if not for life-saving intervention, then perhaps telling a trusted colleague, maybe without disclosing to your employer directly, depending, of course, on the size of your workplace, but disclosing to a trusted colleague might be helpful in case you think you might need assistance, you know, getting back to your office or laying down on the floor or accessing medications in, you know, in a locked workspace, a locked space, or telling them, you know, when you might need 911 to be called or other emergency services. So, gosh, it's a tough question to answer, but I think in most cases, having someone around you know is likely to be more helpful than harmful, even if it's not a full disclosure to your employer. Now, of course, if you were to undergo an ablation procedure and needing time off work in order to do that, in order to do that safely and recover safely, then your back might be up against the wall, having to disclose that. Any electrophysiologist, I'm sure, would provide guidance and a medical excuse if that's helpful in order to be excused from your work, especially if it requires manual labor of any kind, like lifting, which we generally restrict in the few days to weeks after a procedure to allow the groin to heal. So yes, it depends again.
Yeah, only thing I would reinforce, and I think that is excellent and fabulous commentary from Dr. Zeitler, is that it needs to be individualized. Your occupation certainly has a big role into this, and if you're in an occupation where you going into SVT may compromise somebody else's health or well-being, more than you need to just kind of know about that. And specifically, whether it's a superior or others and around you. And these scenarios certainly have come up specifically in my outreach clinic in Lumberton, where We've got a lot of truck drivers or people working construction and things like that. So occupation dependent, once again, individualized, but there are certain scenarios where I think more than just maybe one or two people need to know about potential conditions and anticipatory guidance about what potentially can happen.
Thank you, Dr. Jackson. And moving on to ablation, thank you for explaining that it's not open heart surgery, because that's the first thing most people think, and the entry is through the groin. And often this is done with the person remaining awake, albeit sedated. So how long does the operation normally take? How long will I have to remain in hospital? How soon can I go home? When can I return to work? These are very, very common questions. I'm sure you're asked all these things when someone's about to undergo an ablation.
Sure. I would say that most of the time, electrophysiology study coupled with an ablation is done with conscious sedation, meaning people are given medicines through their IV to make them sleepy and comfortable, but they are breathing on their own without the aid of a breathing tube. I would say most of the time the procedures are lasting, let's say 90 minutes, 2 hours, maybe a little bit longer, just depends on the flavor of SVT or what the actual rhythm is. Typically, these are elective same-day procedures. So I would say the majority of patients are going home the same day. Now that depends on case time, when cases start, and if there are any complications. But generally 2 to 4 hours, same-day discharge using conscious sedation. Patients are sort of breathing on their own, and like I said, generally well tolerated.
Thank you. I really think we have covered everything from all ages and all aspects. And certainly my take-home message is SVT, although potentially not dangerous, it is very individualized, and it's so important for the person with symptoms to get to see a heart rhythm specialist, an electrophysiologist such as yourselves. And when they are diagnosed, to discuss with their heart rhythm specialist, and then go home and discuss with their family, or think it through, or contact Arrhythmia Alliance for our resources, and to actually decide together with their specialist what are the best treatment options to suit their particular lifestyles. It's everyone's an individual, and I think you've really got that message across, which is wonderful, because everyone reacts differently. Dr. Jackson, Dr. Piccini, Dr. Zeitler, is there anything else you would like to add?
Just my heartfelt thanks for the opportunity to provide this education. Doing this work now will help me in the future. My patients will be well informed, and we can sort of get down to brass tacks when we meet. So thank you for the opportunity.
Thank you.
Well, just thank once again your viewership, and once again, Trudy, your leadership, and hopefully we've been able to educate and inform and really help people sort of navigate these complexities around SVT and really make informed decisions that are best aligned with their interests.
Thank you. And Dr. Piccini.
No, I just want to thank the Arrhythmia Alliance as always. You provide such an incredible service for patients and families who are looking for more information that's easy to access and digestible. And if you are out there and you have questions about SVT, or you are suffering with SVT and you want to get your quality of life back to tip-top shape, please contact us. I know Dr. Zeitler and Dr. Jackson are very easy to find and fantastic clinicians. So please reach out. We would love to help you.
Thank you. And we hope in turn that Arrhythmia Alliance will help you with your patients. As you said, Dr. Zeitler, you can now signpost them to this recording so that lots of their questions can be answered. And importantly, they can share it with their loved ones, their families, their caregivers. Because we mustn't forget, it's not just the patient who suffers with the condition, the whole family or work colleagues or whatever living, and they have their concerns. So hopefully we can reach many thousands of people and make your job a little bit easier with lots of the questions so that you can really focus on the treatments and what's best for the individual. Thank you so much for your time. We know how busy you are, so to take time out to spend it like this with us to help those with SVT on behalf of all the patients. Thank you very, very much.